Welcome to Enormous Nephrology. Enormous Nephrology presents the Hypertension Series. This is Volume 6. These talks were presented during the Hypertension Task Force. Volume 1 was an introduction to the Hypertension Series. Volume 2 focused on the KDIGO guidelines. Volume 3 focused on the SPRINT trial. Volume 4 focused on the ACCORD trial. Volume 5 summarized the MDRD trial. And in this sixth volume of the Hypertension series, we shall discuss the AASK trial. Hypertension is a leading cause of end-stage renal disease in the United States, with no known treatment to prevent progressive declines leading to ESRD. African American adults experience a disproportionate burden of hypertension and hypertension-related chronic kidney disease when compared to white Americans. Does aggressive lowering of blood pressure result in slower decline in renal function? Does choice of antihypertensive drug therapy influence renal disease outcomes in African American patients with hypertensive nephrosclerosis? The MDRD trial suggested a potential benefit in prevention of progression of kidney disease with intensive blood pressure control. Published in 2002, the African American study of kidney disease and hypertension, the AASK trial, randomized 1,094 African American adults with hypertension and CKD without a clear secondary cause of CKD to blood pressure targets: intensive blood pressure with MAP less than or equal to 92 millimeters of mercury, or the usual MAP of 102 to 107 millimeters of mercury, and blood pressure medications such as Ramipril, amlodipine, or metoprolol in a 2x3 factorial design. The exclusion criteria included diabetes mellitus, so this trial did not include diabetics, urine protein to creatinine ratio greater than 2.5 grams per gram, congestive heart failure, serious systemic disease, or malignant hypertension in the prior 6 months. Inclusion criteria included African American race, age 18 to 70 years, diastolic blood pressure greater than or equal to 95 millimeters of mercury, hypertensive renal disease with eGFR 20 to 65 milliliters per minute per body surface area. 39 patients who met these inclusion and exclusion criteria underwent a renal biopsy. Most patients had pathologic findings consistent with hypertensive nephrosclerosis. Therefore, these criteria were proven to be useful in identifying patients with hypertensive nephrosclerosis. These are the baseline characteristics of the subjects enrolled in the AASK trial. And as you can see, the patients were randomized to the lower MAP target versus the usual MAP target. There were about 540 patients in the lower MAP goal and 554 patients in the usual MAP goal. The mean age was around 55 years of age. The mean systolic blood pressure was about 150 millimeters of mercury. Mean diastolic blood pressure was about 95. The mean MAP was 115, and the mean serum creatinine was about 2.2 milligram per deciliter in males and about 1.8 milligrams per deciliter in females. The urine protein to creatinine ratio was about 300 milligrams per gram. The 24-hour urine protein was about 600 milligrams, a little bit less, 400 milligrams in females. And significant proportion of patients were on diuretics and calcium channel blockers, and significant proportion of patients were on ACE inhibitors and beta blockers as well. Almost all patients were on any antihypertensive. During follow-up, the mean MAP achieved was about 95 millimeters of mercury in the lower MAP target, 104 millimeters of mercury in the usual MAP target. Mean systolic blood pressure was 128 versus 141 millimeters of mercury, and mean diastolic blood pressure was 78 versus 85 millimeters of mercury in the usual MAP target. Here you can see the mean change in glomerular filtration rate by randomized group. And as you can see, the change in GFR or the trajectory of GFR decline did not actually change with the blood pressure goal intervention. And ultimately, the GFR was similar in the usual blood pressure goal and the lower blood pressure goal. And there was also not much GFR difference between amlodipine, ramipril, and metoprolol. This shows the comparison of mean glomerular filtration rate slopes between the drug groups. And as you can see, in the first 3 months, the usual blood pressure group actually had a slower slope than the lower blood pressure target. And ramipril had a slower slope than metoprolol, but amlodipine was better than metoprolol, and amlodipine was also better than ramipril. But over the first year, the statistical significance between the lower and usual blood pressure targets was lost, and there still remained some statistical significance in that now, metoprolol was had a slower slope than amlodipine, and ramipril had a slower slope than amlodipine. And then the total slope, again, was non-significant when you compared the lower blood pressure target, the lower MAP target to the usual MAP target. And ramipril was better than metoprolol, and metoprolol was better than amlodipine, but ramipril was no different than amlodipine. In an analysis of clinical event composite outcomes, I think the striking thing to note is that when you compare the lower to the usual MAP targets, none of the composite outcomes were statistically significant, whether you stratify it by GFR event, ESRD or death, GFR event or ESRD, ESRD or death, or ESRD alone. This is a graphic representation of the results of the AASK trial, and here we're differentiating between a urine protein to creatinine ratio less than 220 milligram per gram versus greater than 220 milligram per gram. And when the urine protein to creatinine ratio is less than 220 milligram per gram, amlodipine was slightly better than ramipril or metoprolol. And ultimately, there was not much difference in terms of changes in GFR from baseline. And if the urine protein creatinine ratio was greater than 220 milligram per gram, then ramipril was actually graphically better than amlodipine. But still, the change in GFR from baseline remained non-significant. Here you can see that proteinuria was actually much reduced in the lower blood pressure target. So there was a benefit in reduction of proteinuria over the course of the AASK trial. And the other striking thing to note is that ramipril is definitely better than amlodipine in terms of reducing proteinuria. So there was a benefit in reducing proteinuria with the lower blood pressure targets, the lower MAP targets. And the rate of adverse events was actually quite similar between the lower and usual blood pressure targets, as well as between the different medications, the ACE inhibitor, calcium channel blocker, or beta blocker. Here is a comparison of antihypertensive therapy and blood pressure during follow-up. You can see that in the lower blood pressure target, The MAP was 95 versus 104 millimeters of mercury. Systolic blood pressure difference was 128 versus 141 millimeters of mercury. Diastolic blood pressure was 78 versus 85 millimeters of mercury. And also you can see here that the total number of antihypertensive drug classes was about 3, a mean of 3 in the lower blood pressure group versus 2.42 in the usual blood pressure group. So obviously use of a greater number of antihypertensive medications in the lower blood pressure target, which would be expected. And the other thing that might be expected would be that use of non-traditional medications was greater in the lower blood pressure target, such as doxazosine, clonidine, or minoxidil. Strength of the ASK trial was that there was a focus on a specific high-risk population, that is, the African American population. And the ASK used a strong, multi-center, randomized, controlled 2x3 factorial design to evaluate 2 blood pressure targets and 3 antihypertensive medications. But again, the same criticism which is valid here, which can be equally applied to many other hypertension trials before the SPRINT and the ACCORD trials, is that they used MAPs. And when you compare 2 different MAPs, mean arterial pressures, you're not actually looking at specific systolic or diastolic blood pressures. And so by calculating the mean arterial pressure, you could actually have very varied systolic pressures, very varied diastolic pressures in your patient population. The SPRINT and the ACCORD trial were the first to establish specific systolic blood pressure targets, i.e. 120 over 80 versus 140 over 90. The ASK trial did have a long duration and comprehensive follow-up, and throughout both the trial and cohort phases, blood pressure was well controlled in participants, allowing for a clear assessment of outcomes at different sustained blood pressure levels. The ASK trial did have its flaws, of course. There was a lack of power for cardiovascular outcomes. But that dichotomy does exist, will exist, because if you look at cardiovascular outcomes, you will not emphasize renal outcomes. And if you look at renal outcomes, you'll have a paucity of cardiovascular outcomes or lack of emphasis on cardiovascular outcomes. And then it becomes the responsibility of kidney organizations and cardiology organizations to somehow synthesize this data to come up with guidelines specifically geared towards the CKD population or the cardiovascular population or the general population. The ASK trial used traditional office blood pressure measurements. Later research highlighted the importance of ambulatory blood pressure monitoring, as a significant percentage of ASK participants had masked hypertension, i.e. normal office blood pressure, but high out-of-office blood pressure, which was associated with poor outcomes. The reliance on office blood pressures may have affected the results. A portion of eligible participants declined to enroll in the long-term cohort study, with those who did not enroll being older, which could introduce some selection bias in the follow-up phase. In summary, there was a mean separation of approximately 10 millimeters of mercury of mean arterial pressure, and this was maintained throughout most of the follow-up period. The mean rate of decline in GFR did not differ significantly between the lower and usual blood pressure groups over the total follow-up period from baseline to 4 years. Similarly, there was no difference in the incidence of end-stage renal disease, 50% decline in GFR, death, or a composite of these events between the 2 blood pressure groups. There was a trend for greater benefit of the lower blood pressure goal in patients with higher baseline proteinuria, but this did not reach statistical significance. The only beneficial effect of the lower blood pressure goal that could be demonstrated was that proteinuria increased by 7% in the usual blood pressure group and decreased by 17% in the lower blood pressure group during the first 6 months. These differences between treatment groups persisted throughout the study. There were no differences in adverse effects or cardiovascular outcomes between the two blood pressure arms. Points to take away from this talk is that the AASK study demonstrated that additional blood pressure lowering could be achieved and maintained in a population that is traditionally considered as difficult to control. This finding is important in the context of recent data implicating proteinuria not only as a marker but as a mediator of progressive renal injury. It is possible that the beneficial effects of the lower blood pressure target may manifest initially as lower levels of proteinuria, raising speculation that with a longer duration of follow-up, clinically apparent benefits may be derived. Indeed, when you combine the MDRD plus the AASK trial, it becomes evident that intensive blood pressure lowering was not associated with increased risk of death or ESRD among any subgroups that were examined. So intensive blood pressure lowering did not increase the risk of ESRD and did not increase the risk of death among any subgroups that were examined. And indeed, after a follow-up of 15 years, intensive blood pressure lowering did reduce mortality. So that confirms the suspicion that investigators had that initial improvement in proteinuria with the lower blood pressure target did translate into reduced mortality over the long term, and that lowering blood pressure or adhering to a lower blood pressure target did not increase the risk of ESRD and did not increase the risk of death. So volume 1 of the hypertension series discussed the goals of the hypertension series. Volume 2 examined the KDIGO guidelines, discussed the KDIGO guidelines. Volume 3 looked at the data from the SPRINT trial. Volume 4 analyzed the data from the ACCORD trial. Volume 5 discussed the MDRD trial. Volume 6, which is this existing volume, summarized the AASK trial, results of the AASK trial. In volume 7 of the hypertension series, we will discuss low renin essential hypertension, which is actually a phenotype present in about 30% of hypertensives, but almost 70% of resistant hypertensives. So it's an important condition, important phenotype to understand. It can guide treatment, and understanding low renin essential hypertension is very important. And then we will discuss resistant hypertension and management of resistant hypertension. And we'll discuss epidemiology, diagnostic criteria, management, and discuss what remains unknown or uncertain. So see you next time. This is a presentation of enormous nephrology. Enormous nephrology started off as a board review series and then branched out into individual topics which were of interest to listeners and viewers. So please send me some comments, send me some requests, and I shall honor them as possible. Thank you very much. See you next time.